adult perspective, though it can be generalized. So first, I'll be talking about what connective tissue disease is to a rheumatologist. Next, the presentation of connective tissue diseases, some important points in the investigations that we do for these patients, the ANA and ANA profile and its interpretation, a basic overview of management with a look specifically at certain treatment modalities and drugs, and finally dinner, hopefully in that order. So coming to connective tissue diseases, as a rheumatologist, we tend to consider SLE, myositis, systemic sclerosis, Sjogren's, undifferentiated connective tissue diseases, and overlap syndromes as connective tissue diseases, whereas routine inflammatory arthritis such as rheumatoid arthritis, spondyloarthritis, crystal arthropathies, and vasculitis is not considered as connective tissue disease for the rheumatologist. So coming to presentation, first is photosensitivity. That is probably the first history that we take from patients. In fair skin patients, just getting an erythema might not be specific. Itching and visible skin lesions make it more specific, and you should look at other sun-exposed parts, upper back, forearms. So just wanted to show this to patients. This patient has your typical nasolabial sparing, as you can see here, whereas this patient has no sparing of the nasolabial fold. This is a case of SLE, whereas this is a case of dermatomyositis. As well as you can see exceptions. For example, in this patient, there is both involvement on one side, the nasolabial fold, as well as sparing. This was a case of SLE. So slight atypical appearances was also seen. Next thing is an oral ulcers. Oral ulcers tend to be recurrent, painful, involving the hard pad, and it's very well for SLE. Few other pictures I just wanted to add. This was a patient of SLE with chilblain lupus who had cold-induced vasculitis-like lesions on her fingertips. These are two patients who, on the left side, was an old lady who was being recurrently treated for allergy. And when she presented as a bystander to another patient, I noticed she had this heliotrope rash over her eyes, and on further evaluation, she had a slightly increased muscle enzymes as well as ANA positivity, and was found to be a hypomyopathic dermatomyositis. The second one is a juvenile dermatomyositis, young girl with again a significant heliotrope rash. I don't know if you can make out in the picture. And then this is another patient who was being treated for mild arthritis, but she had significant Gorton's papules. You can see on the knuckles here. These are also Gorton's papules seen on the knees and the elbows. So subtle clinical clues are important. Hair loss, it has a very poor specificity, especially in female patients. Most of them tend to have this issue. But sometimes when you ask for severe hair loss, where hair is lost on the bed or pillows in the morning when they wake up, it tends to be a little bit more specific. Another thing is the Raynaud's phenomenon. So the Raynaud's phenomenon can be both complete or incomplete. Sometimes patients might just complain of increased cold sensitivity rather than other changes, especially in warmer climates, tropical climates like in Kerala. And a challenge test may be used wherein you ask the patient to dip their hands in a bowl of water, which was kept in the fridge for about half an hour, and then take photos before and after at home. A simple way to challenge this thing and to find out if they have Raynaud's phenomenon. Or you can keep the OP AC very cold and then make out in the OP itself. So these are three pictures showing Raynaud's phenomenon. One is the blanching, the cyanosis, followed by erythema, and then finally it clears. Some patients may have only blanching, in which case it is known as incomplete Raynaud's phenomenon. Another common symptom is fever, which is usually intermittent. It lasts longer than 2 weeks, and multiple investigations might not show a proper cause for infection. Another common symptom is fatigue. Fatigue is very common even among patients without connective tissue diseases. So possibly it could be ignored, but there are a significant number of patients with primary Sjogren's who present with fatigue alone. So patients, especially ladies, female patients who present with fatigue, always think about primary Sjogren's. Possibly you can get a history of dry eyes, dry mouth in those patients. Next is skin. Skin is possibly one of the most commonly affected in connective tissue diseases. Rashes, especially in sun-exposed areas, as told earlier. Another thing I wanted to bring your notice to is about sclerodactyly. So we tend to see that patients tend to have tight skin sometimes. We think it could be sclerodactyly. Usually in sclerodactyly, there usually is facial tightening as well. There is a taut facial skin, simple ways to pull down the lower eyelid. It tends to be a bit tight. If you see this picture here, the way you define sclerodactyly is actually this part, the area in red, enclosed by the red circle. Because it should be between the MCP joint and the proximal interphalangeal joint. So sometimes you see patients who have tightening of the skin distal to the proximal interphalangeal joint, maybe work related or something, but those are not considered as sclerodactyly. This part which has to be thickened or tightened on pinching. Another thing that you should always look for is weakness, where you look for a proximal muscle weakness. Distal weakness, unless the patient is a case of inclusion body myositis, usually is not connective tissue disease. Generalized weakness is too non-specific, happens for a lot of patients, so hard to say that is significant. And simple and quick ways to assess in the clinic is possibly keeping your hands in a wing sort of position and pushing it down on either side and asking the patient to push it up, and then pushing against the fingers of the head, because neck weakness might be subtle and it's something that you should not miss. Next is arthralgia, arthritis, probably another common symptom in connective tissue diseases. It usually presents with an early morning stiffness. That is possibly one of the easiest ways to find out if the pain is significant with relation to connective tissue disease or not. It is usually non-erosive in connective tissue diseases. It can be both poly as well as oligoarthritis, and it may only be the presenting symptom with nothing else, no skin, nothing else. Eyes are a very important part of clinical examination, where you need to probably primary or secondary Sjogren's is the most common problem encountered with dry eyes. The simple test, Schirmer's test, which is available in with most ophthalmology centers, will help you in diagnosis. There will be a wetting of less than 5 millimeters in the filter strip. It affects these connective tissue diseases can affect every part of the eye, from front to back, and sometimes when there is a retro in the posterior compartment involvement, possibly you might not see much symptoms anteriorly. Fundus in all patients should be looked at, and retinal vasculitis should not be missed. Coming to investigations, the most simple one, CBC with peripheral smear. Here, cytopenias should be looked for. Leukocytosis and thrombocytosis, always think of adult onset Still's disease versus vasculitis. When there is anemia in these patients, always consider autoimmune hemolytic anemia. Always look at the peripheral smear, there might be reticulocytosis. And when you see any anemia in this patient, always send a direct Coombs test and the serum LDH. Serum LDH is pretty sensitive to pick up hemolysis. But if there is myositis as well, the LDH might be elevated without hemolytic anemia. And another thing that we cannot miss in these patients is microangiopathetic hemolytic anemia. In these patients, the peripheral smear might show schistocytes. Another simple way of picking up muscle involvement is the presence of an increased SGOT in relation to SGPT. Sometimes we think of alcohol-linked disease, and another reason for an increased SGOT than SGPT. Always think of muscle involvement in these patients. In these patients, when the SGOT is more than the SGPT, always do a CPK total, a serum LDH, and if the CPK is very high, possibly a urine for myoglobin to see if there is a mild form of rhabdomyolysis. It is usually seen in patients with necrotizing myositis. Another thing from clinical experience that we have seen in our institutes is that the patients with a high ALP, especially in SLE, they tend to have a very bad prognosis. They tend to have severe disease, GI vasculitis, GI involvement, and they tend to have a bad prognosis. Thrombocytopenia is very common. In rheumatology, we tend to give more importance to something less than 1 lakh rather than 1.5 lakh. Possibly patients with counts between 1.2 to 1.5 with a manual platelet count might have something in the normal range. And always in thrombocytopenia, think of antiphospholipid syndrome. It can present with thrombocytopenia alone. Another thing is an altered INR or APTP. Most of these patients, especially when they come late to the doctors, they might be malnourished, and vitamin K supplementation might help in these patients. APTT prolongation, always think about lupus anticoagulant positivity as a cause. ESR is usually increased. It's very non-specific, but it helps. It may correlate with disease activity, but not always. And in Sjogren's syndrome, polyclonal hypergammaglobulinemia may cause increased ESR with not much disease activity per se. So what you have to look at is the albumin globulin ratio. Usually there is a reversal, but the levels are the albumin levels are normal, whereas the globulin levels are elevated, and this causes an increased ESR. CRP is always normal in SLE except when there is arthritis, serositis, that is pleural or pericardial effusions, and infection. So a patient with an increased CRP with features of SLE, we need to look at all this. Serum creatinine is usually affected later in CTDs compared to vasculitides. In an SSE patient, scleroderma patient with an increasing serum creatinine, always think about a renal crisis. Renal crisis, you should never use steroids in these patients more than 15 milligram per day. It tends to push them to a renal crisis, and especially in diffuse cutaneous. Limited cutaneous, the correlation is not that strong, but in diffuse cutaneous systemic sclerosis, usage of more than 50 milligram per day prednisone is a high risk for scleroderma renal crisis. When renal creatinine is increasing along with abdominal pain, also think of renal arterial or venous thrombosis, which could be secondary to APS positivity. Low C3, C4 is another important test showing the deposition of immune complexes, but it could be skipped initially if the other features are there, because it's just cut down costs. A simple, very important test is the urine routine microscopy. It is highly underutilized. Usually we ask them to do on the first morning samples. There should be a low threshold for 24-hour urine protein in these patients with features of connective tissue disease. You can go for a urine protein creatinine ratio, but I have seen patients with a normal UPCR with a high 24-hour urine protein. I tend to prefer the 24-hour urine protein, even though it's a little bit more cumbersome. So when do we go for a renal biopsy? One is a bland. When do we go for a renal biopsy? One is a bland proteinuria more than 1000 milligram per day, or if there is a proteinuria more than 500 milligram per day with active sediments, that is pus cells, the presence of RBCs or CAS. As we have seen in our urine routines, we rarely see CAS being reported. So possibly with pus cells and RBCs itself, you can consider them as active sediments. Another important antibody that we should not miss is the antiphospholipid antibodies. In the laboratory chains that we see around, there are many tests which are considered as antiphospholipid antibodies. But when you want a proper evaluation for APS, always send it as separately: glucose anticoagulant, anti-beta 2 glycoprotein 1, IgG and IgM, as well as anti-cardiolipin IgG and IgM. It should be done ideally in all SLE patients and every patient with a connective tissue disease planning pregnancy. In positive cases, it is always important that we repeat it after 12 weeks, minimum after 12 weeks. Only then APS can be considered as a diagnosis, and IgM antibodies tend to become negative with time. So this repeating after 12 weeks is very important. Then further organ-specific investigations as necessary. You can go for MRI, brain, thighs to look for myositis, muscle involvement, help you with biopsy, muscle biopsy in myositis. CSF analysis to see aseptic meningitis, which is pretty common in SLE. The neuropsychiatric SLE with increased cells in the CSF. Renal biopsy, as said earlier. 2D echo. Patients with antiphospholipid antibody syndrome can have subtle LV dysfunctions, especially in SLE. So young females with an antiphospholipid antibody positivity with a sick sort of presentation, always rule out LV dysfunction. CCT abdomen, possibly to rule out GI vasculitis if the patient has symptoms, and a CTPA. If antiphospholipid antibody is positive, rule out pulmonary embolisms. So coming to ANA and ANA profile, which is possibly the most commonly sent test in these patients. So this is the table from Kelly's textbook of Rheumatology 11th edition, in which they have just given a few points, which I want you to see this. So 100% in which ANA is required for diagnosis is drug-induced lupus, MCTD, and autoimmune hepatitis. Whereas even in SLE, with the latest techniques, up to 99 to 100% are positive in ANA. But you can have an entity called ANA negative lupus, which is very, very rare. Also, it is useful in juvenile idiopathic arthritis. In these patients, if ANA is positive, then the patients may develop uveitis. Antiphospholipid antibody syndrome with ANA positivity, the patient may go on to develop a CTD, especially SLE. And patients with simple Raynaud's phenomenon with the ANA positivity can develop a connective tissue disease with time. So, other thing is, Patients in which it is not useful. So discoid lupus erythematosus, ANA is not always required. Fibromyalgia, other arthritis, relatives of patients with autoimmune disease, we just increased psychological stress for them by doing an ANA. Multiple sclerosis, ITP, possibly you can go for an ANA in these patients. We do tend to see SLE presenting as ITP alone. Thyroid disease, patients with silicone breast implants, even though ANA is positive in these patients, it's not significantly pathogenic. Infectious disease and malignancies, very high incidence of false positivity. Another thing is in normal individuals, even healthy individuals, up to 30%, 20 to 30% of normal individuals may be positive if you take the ANA titer more than 1:40. Most laboratory chains now take a titer of 1:80 and above. In institutes, we used to use a titer of 1:100 and above. In patients above the age of 65, up to 10 to 37% of patients may be positive for ANA. And medication-induced ANAs are not always pathological. This is just a table showing the various patterns that you see with ANA, and from these patterns we are able to guess which antibodies are possibly positive. This was more important previously when the ANA profile was a little hard to do, more costly. But now with the easy access to ANA profile, possibly the patterns and this thing is more of a rheumatologist interest rather than clinical utility. So then there is another question: why would you go for an ANA ELISA or ANA IF? So ANA IF is more sensitive. IF, I mean immunofluorescence, is more sensitive. Cytoplasmic patterns are better picked up. It is recommended by the major rheumatology bodies to go for an ANA IF. Patterns may suggest the diagnosis, but with an ANA profile, you can skip that. And it is more confidently you can rule out CTDs with ANA IF. Whereas ELISA, they are less sensitive, though there are newer ones which have in studies shown equal sensitivity as ANA IF and specificity. And conformational antigens may be missed. Conformational is 3D structure. Sometimes the antibodies act against the 3D structure, an antigen in a 3D structure. So in these ANA ELISA, when it is coated on the wells, the 3D structure may be lost and we might get a false negative. But it is easier, quicker, less technical. There is a quicker turnaround time with a lot of false positives. So what is the ANA profile? The ANA profile is also known as the ENA, or the extractable nuclear antigens. It was initially used as the term for a group of nuclear antigens extractable by saline solutions. It is actually a misnomer because right now, with identification of newer autoantigens within various compartments of the cell, including cytoplasm, ENA is not used much. Relatively insoluble nuclear antigens and or cytoplasmic targets are all part of ENA. So what are the indications for ANA profile testing? One, it is to establish a diagnosis of connective tissue disease with suggestive clinical features. That is the most important part. It is to exclude connective tissue diseases in patients with a few or uncertain clinical findings. It can classify patients known to have CTDs into prognostic groups. It helps in monitoring disease activity. Sometimes with time, there is something called epitope spreading, especially in SLE, where new antibodies tend to become positive. It is not to be used for general screening. Sometimes we see without doing the ANA, we go for an ANA profile directly. The patient is anyway, we are trying to cut the cost. But the issue there is with ANA profile, there tends to be a higher false positivity rate. There is an overdiagnosis of CTD with going for the ANA profile alone. It is ideally better to send an ANA IF and the ANA profile together or subsequently. That is, first the ANA IF, if positive, go for the ANA profile. And it is especially problematic when the ANA profile shows 1+ positivity of autoantibodies. You are not sure whether how significant it is. The patient has odd symptoms. In that situation, I tend to go for an ANA IF. If it is negative, ignore the ANA profile. So the immunoprot or the line immunoassay is what is used for this thing, ANA profile. This is a strip, a nitrocellulose strip with each antigen coated on it. So the only SLE specific antigens here is the dsDNA and the SM SM antigens. Whereas in SLE, all these antigens may be seen: dsDNA, nucleosome, histone, SM, pCNA, and ribosomal P. All these can be seen in SLE. Next is the ones associated with Sjogren's syndrome, which include SSA, SSD, and Rho52. The third group would be the ones which are associated with scleroderma, that is the centromere B antigen, and SCL70. The fourth one is U1SNRP, which is associated with mixed connective tissue disease, though it is very commonly seen in SLE as well. The last one is those with associated with myositis, these four antibodies. If you can see here, AMA includes a common antibody that is seen positive. It is associated with primary biliary cirrhosis, but we tend to have its positivity in a lot of connective tissue diseases. The only thing I could suggest is when it is positive, always look at the liver function a little bit more closely. This is a picture of the strip after the antigens have become positive and it has been placed for the ANA profile scanner. This is a sort of flow chart which might help you to decide about what antibodies to search for. I just want to bring your attention to this part. So patients who are having a suspected ANA disease, the features of a suspected ANA disease, if your ANA IF or immunofluorescence is either a low titer positive or it is negative, you can consider for checking anti-Rho 60, that is SSA, anti-tRNA synthetase, because these are cytoplasmic antigens. These antigens previously were not reported in ANA reports from large laboratory chains, but it has changed now. And then the antiphospholipid antibodies, some thrombotic manifestations in a patient with doubtful CTD-like features could be due to antiphospholipid antibodies. So then next we come to the graphical representation of ANA profile. It is always important to look at the length of the control positivity. I'll come to that in the next slide. Issues can rarely occur after pulse steroids, and especially in patients who have received IVIG. The control positivity might be reduced. In that sense, in that case, we'll have to look at the other positivities in context of the control positivity. And always remember, borderline positivity is taken as negative. Again, looking at the graph is important. So I'll just show you this graph of a patient who presented with fever, oral ulcers, skin lesions. So here you can see the control. This is the control graph. That is strongly positive. So that is right. But then, if you had not received the picture of the ANA strip, what happens is, if you look here, it's a bit dirty. There's a few lines here and there. It's a bit dirty. And if you look at the same sample being repeated once again with more technical they did it more carefully. You can see the control is again positive, but the strip is more clean. There are more perfect lines, and the antibody positivity has changed. So this is why it is important to look at the strip as well as the graph, at least the graph, because most of the laboratory chains, many laboratory chains, do not provide the graphical representation of ANA profile. So this is not ideal. Then there's something you might have come across as something called a myositis profile. So myositis profile is basically a number of antibodies which is associated with the inflammatory myositis, of which the ANA profile has these antibodies. MI2 is considered together in ANA profile. Anti-2, anti-PMSCL is considered together, anti-Jo1 and anti-Rho52. All these antibodies are there in ANA profile, but there are a number of other antibodies which can be associated with significant inflammatory myositis, which is negative on an ANA profile. So these patients may be ANA positive, ANA profile negative, but with myositis and significant involvement. One entity I would like to bring your attention to is anti-MDF5 dermatomyositis. I told earlier, it does not come on an ANA profile. It comes only on a myositis profile. It is a melanoma differentiation associated protein 5. It is associated with rapidly progressive ILD. The patient can go into severe ILD in a period of months, and it has a very poor prognosis. One clinical characteristic is all these cutaneous and oral ulcers, and there are palmar papules with alopecia. These are typical MDF5 lesions on the hands. As you can see, it might be a little similar to the Chilblains lupus that we saw earlier. Next is, we see a lot of patients being diagnosed as MCTD, mixed connective tissue disease. So there is something called an undifferentiated connective tissue disease where you cannot fix the patient into one particular entity, but mixed connective tissue disease has particular criteria to be called so. The most important thing is anti-SMRMP positivity. So unless a patient has this antibody positivity, that too in high titer, you cannot call a patient as mixed connective tissue disease. So it is not simply a literal translation that MCTD is a mixture of different connective tissue disease. You would rather call that as an undifferentiated connective tissue disease and not MCTD. Also, the positivity, presence of positivity to anti-Smith, ESDNA, SCL70, RNA polymerase 3, anti-synthetase, and anti-MDA5 In the latest criteria from Japan, they have said that patients with positivity to these cannot be considered as an MCTD. We need to work up further. Simple overview of the principles of management. For mild disease activity, NSAIDs are safe unless there is renal involvement or anti-malarials. Low-dose corticosteroids may be useful for mild to moderate symptoms, whereas in severe systemic disease or internal organ involvement, they may require high-dose steroids and further immune suppression. Steroid-sparing agents include azathioprine, methotrexate, mycophenolate mofetil, cyclosporine, tacrolimus. And when there is major organ involvement like CNS and renal, more intense immunosuppression with cyclophosphamide or rituximab may be required. I just want to mention a few points about hydroxychloroquine, which many of us use for several indications. We need to keep the dose below 5 mg per kg. We see patients with 40 kg patients who are getting 200 mg BD of hydroxychloroquine. These patients are getting a per kg weight dose of 10 mg per kg. These patients can develop retinopathy within a few years rather than 5 years, which is the usual thing seen with patients with getting a dose less than 5 mg per kg. The most important issue with hydroxychloroquine is retinopathy. Initial screening is required only in high-risk patients. That is the latest RCO 2020 guidelines, Royal College of Ophthalmology. And initially, when you're starting HCQS, you don't need to check whether the patient has any issues unless there is some previous ophthalmic issues. If the patient is an older age group, renal disease, or if they're using tamoxifen. If the patient is using tamoxifen, it is better to avoid HCQS along with it. Otherwise, all you have to do is check for a HCQ retinopathy after 5 years of use. And these are the 3 tests that we usually send, 10-2 and 30-2 or perimetry, automated perimetry. Possibly doing both will be very stressful to the patient. In the studies, they've shown that Asian patients tend to be more positive on 30-2. So probably you can send 30-2. SD-OCT macula and fundus examination. All these 3 are required. These 3 alone are required. And if both are positive only, SD-OCT as well as automated perimetry show defects, then only can you say it is a definite retinopathy. Fundus examination usually does not show anything on early HCQ retinopathy. It is a cornerstone in SLE management. We tend to have a lot of issues with patients on HCQ who develop retinopathy, possibly reducing the dose and giving us this thing, but I'm sure many of the ophthalmologists might not agree. Avoid morning dosing. This is another thing that we see very commonly. The drug by itself may increase photosensitivity paradoxically. So there is a higher chance for hyperpigmentation when you give HCQS in the morning. So always give HCQS in the night alone. It is uncommon, but then once the hyperpigmentation comes, it is difficult to change. And another thing is avoid breaking the tablet. So for example, a patient with 50 kg, 5 mg per kg, we need to give 250 mg per day. It is very easy to give them 300 mg 5 times a week, which is more than enough. It has a very long half-life. It will work the same way as you're giving the tablet every day. So avoid breaking the tablet. And it is not to treat all kinds of arthritis drugs. We see patients with spondyloarthritis, psoriatic arthritis, all receiving HCQS. Psoriasis can be flared up by giving HCQS. So possibly we need to see what kind of arthritis we are treating before we give HCQS. So coming to pulse steroids, I just wanted to mention few of the drugs specifically. So how do we define the dose of steroids? Low dose is something below 7.5 mg per day. Medium dose is 7.5 mg to 30 mg per day of prednisolone equivalent. High dose is 30 to 100. Very high dose is above 100, and pulse therapy is something that is above 250. So pulse therapy is whenever you give a 250 mg or more of prednisolone equivalent any other steroid. So we use it only for severe life-threatening or organ-threatening disease. And in lupus nephritis, initial use of pulse steroids helps you to start with a lower dose of oral steroids, 0.5 to 0.75 mg per kg instead of 1 mg per kg. It is not indicated for arthritis. Usually we do not pulse the patient for arthritis. We have to remember even 2 cc DEXA is equal to 56 mg of prednisolone. So when you give 2 cc TDS for a patient, just imagine what dose we are giving. Next about IVIG. So IVIG, the dose that we use is usually 1 gram per kg per day over 2 days or 400 mg per kg per day over 5 days, depending on the patient status, renal status, cardiac status, everything. So where do we use it commonly? One is severe myositis with respiratory muscle involvement. That's why I wanted you to consider neck muscle involvement in all these patients. The moment the patient has a neck weakness, always be careful that the patient may have a pharyngeal weakness as well as respiratory muscle involvement. Second thing is a rapidly progressive ILD or scleroderma. Both these patients may be helped with IVIG. Severe secondary immune thrombocytopenia can also be helped with IVIG. And then macrophage activation syndrome, most of us would have heard it in the COVID scenario, and catastrophic antiphospholipid syndrome, where more than 3 organs are involved in a very short span of time in antiphospholipid syndrome. So these are the main commonly used situations, commonly seen situations where IVIG is helpful. The major issue with IVIG is the cost. Another thing that we always miss in these patients is asking them to avoid sun exposure. We tend to not, we possibly during practice, because of time constraints, we tend to miss this. But sunlight avoidance is very important. Sunscreen and protective clothing, especially in a state like Kerala, where there's a tropical climate. UV exposure can exacerbate both systemic as well as skin disease. Another thing that we also do not give much importance to is home lighting. So the old bulbs, the tungsten lighting is generally safe. Halogen bulbs are not commonly used, but they have issues. Fluorescent lighting, CFL lamps, they tend to emit UV radiation. It is actually unsafe for patients with SLE. Like LED bulbs, there are two types. There is the cool white bulbs that we usually use, and the warm white, which has a more of an orange tinge. The cool white bulbs tend to produce more UV, and so they might not be preferable in patients with photosensitivity. So coming to the take-home points that I want to mention. One, ANA, and in certain instances, ANA profile positivity does not mean CTD. History and clinical examination are more important. Second, early recognition and early institution of treatment is crucial, maybe life-saving. The simple urine routine examination is a very important part of the lab investigations. Graphical representation of ANA profile is important, possibly helps you avoid mistakes. HCQ is an important drug, but not a panacea. Steroids are a lifesaver in many of these patients, but if you use it for the optimum dose and the optimum duration. So steroids are not the villain. It is possibly a lack of proper dosing or duration of dose that is a problem. Thank you.
For the excellent and efficient talk on CTD, the topic is common course.
So possibly, I would say Kerala is much better off. I think from my experience while doing my training in UP, in comparison to UP, Kerala is much better off. There is much more wider recognition that there is something called as CTD infections. But yes, like you said, sir, there is a lot of mismanagement, and we tend to miss things when the patient is not evaluated fully. A simple example would be a rheumatoid arthritis patient who's being treated for a long period of time and an IUD is missed. And the moment the patient presents with a severe significant breathlessness, possibly it is a point in time where drugs might not help much. So that is there, but the situation is much better than possibly many other parts of the country. The etiology is always up for discussion because one, genetics is a small part of the problem. Environment is a significant reason. Lifestyle issues are also a significant contributor. But so there are genetic issues, certain familial genetic issues where you tend to see more CTDs, but majority of the CTDs, I would not say there is much endemicity. So I do not think there is any such data, but there are in patients with familial genetic syndromes which resemble CPD, like SLE, there are Eckhart-Gutier syndrome, for example. So those may be consanguinity or an issue, but otherwise no. But first degree relatives of the patient with autoimmune disease have a higher chance to develop. So that is an issue, but I feel if initially you are able to counsel the patient properly, possibly take a little bit of time in the first visit, I think that goes a long way in preventing them from going. Most of the time, patients going to another alternative has one lack of research, a lack of symptom relief, and third thing is a lack of knowledge. So if you are able to just explain to them slightly what we are facing, possibly we can reduce the number of patients going to alternative medicine. So most cases, patients who go into remission because they are there, but the number of drugs required for management may reduce.
Recently, you are not probably diabetic retinopathy was the most underdiagnosed field. When physicians are not referring cases to ophthalmologists on a regular basis, this the patient complaints of subcultural. But now it's a change. When the diabetic is not very what percentage of patients only get the check the proper way. Because the direct outcome was to see it is nothing. So, see, the only latest practice they have to use that very so now it has improved. So there is no awareness. Likewise, it's also most of the patients, I think, we are getting a small sample of the patients. Still, a lot of undiagnosed cases or misdiagnosed cases and is the treatment.
Yes, sir.
Because a lot of awareness.
Yes.
Other than patients.
Yes. During training, even when I was doing my MBBS training, this was a very dry area of medicine where we tend to skip for exams.
Most of this specialty is directly goes to students.
Yes, sir. Usually, no, sir. But then that's what I said, sir. I think in our state, even patients are a little bit more informed, possibly compared to other states. So that has helped. There are a lot of patients who know what rheumatology is. So that is. So in inflammatory arthritis, especially rheumatoid arthritis, most of the patients will develop deformities if they are not managed properly. But if managed properly with minimal deformities, I don't think there is a big issue there. In inflammatory tissue diseases, more than deformities, they rarely have corrosive arthritis. They tend to develop organ involvement. That is more problematic. It affects the organ.
Was excellent presentation. Something important thing about this is your Kannur message. One more thing to be added that Kannur message is do not reach after successive. Other area is what some mentioned is also as answer that you have to prescribe. Answer should mention what are things that should be done to this patient or disease. As I mentioned, every 6 months of the consultation, or every 2 months. Like that, if you educate personally, the first or second visit itself, this follow can be solved. Another issue is regarding the other options of physiotherapy. Let's say acupuncture or some Chinese medicine. I think in this your as I am a member or I am a related person, we cannot think of systems. So most of the patients are getting to live by doing this type of modified physiotherapy.
Sorry, I'll just interrupt you in that. Sir, if you look at any study, any drug that any randomized control trial, the placebo rate is 20 to 30%. So
placebo rate?
Why is there a placebo rate? A patient with severe inflammatory arthritis having a placebo rate. ACR 20 response, which is considered as one of the responses.
The rate is up to 20,
The rate is up to 20, but see some have an ACR 50 response.
I believe
So I believe that this is just a placebo.
always mix up the DNA.
Always mix up the DNA.
Physiotherapy
But physiotherapy per se, one of the most important parts of the diet, that even I guess possibly the very part we also tend to.
That is definitely
There's a, I still feel that the remaining part that you mentioned is possibly just a placebo.
That system, just like physiotherapy, this but I think the doctors are not stressing on that area. They will be going through this medicine and changing the mode. But I think patients are getting relief if they are doing some sand therapy, not sand therapy.
Possibly we are not trained about all those things, but I don't think we will also support those kind of things. I think proper physiotherapy per se, the training physiotherapist is more than enough. Many of them, the techniques that they use, including infrared or that ultrasonic therapy, it tends to bring very good results. The only issue here is that patients tend to not go again. They go once, they don't go again. So possibly there also a little bit of counseling from the physiotherapist, telling him about few sessions, which might make a big difference.
So physiotherapy definitely
other things are possibly more of placebo effect. Strongly believe,
but there are studies in, for example,
osteoarthritis or acupuncture.
Small amount, it was very small amount issue because minor arthritis, adult 15 plus, 50 plus. So the RPP also says around
the thing is, rapid tissue disease patients do, especially in those with inflammatory arthritis, they could tend to have a higher
incidence of cardiovascular disease compared to the general population. So possibly a better or more closer watch of these patients and then deciding on microscope would be better. And the only indication where probably you can start microscoping straight away when a patient without manifestation is an SCE patient with ABS positivity, antiphospholipid antibody positivity. Those patients we tend to be microscoping lifelong. But other than that, possibly
as an NSA,
but the low dose aspirin has given
to no effect as a painkiller. Maybe.
since exists
Kannur Ima football team in the Perry FC Kannur Ima and FC Kannur Ima. Club in a bit of Portugal, sir.
President, respected members, senior members, all. Football team, IMA state-wise football matches district-wise team district best players there's a match between various IMA branches of Kannur, each district. Kannur district team Kannur team Kannur team Rajmohan other than leader captain youngest child of captain. But another players in the back next 23rd Monday on fix the match. One day program. അപ്പോ നമ്മുടെ ടീം ഒരു ജേഴ്സി എനിക്ക് തോന്നുന്നത് IMA ആണ് സ്പോൺസർ ചെയ്തിട്ടുള്ളത്. അപ്പൊ ജേഴ്സി എല്ലാം റെഡിയാക്കിയിട്ടുണ്ട്. അപ്പോ നിങ്ങളുടെ എല്ലാവരുടെയും വെൽ വിഷസ് നമുക്ക് വേണം. നമ്മൾ കപ്പുമായിട്ട് വരാൻ വേണ്ടിയിട്ട് നിങ്ങളുടെ വിഷസ് ഉണ്ടായിരിക്കണം. അപ്പോ ഫുട്ബോൾ, സോക്കർ 23rd. അപ്പൊ താങ്ക് യു വെരി മച്ച്.
നമ്മുടെ പുതിയ മെമ്പേഴ്സ് വന്ന് സെൽഫ് ഇൻട്രൊഡ്യൂസ് തന്നായിരുന്നു. ഫുട്ബോൾ ക്ലബിന് ഒരാൾക്ക്
ഡോക്ടർ അബൂക്കറാണ്, അഴീക്കോട് ജനറൽ പ്രാക്ടീഷണറായി വർക്ക് ചെയ്യുന്നു. ഡോക്ടർ മുഹമ്മദ് റജീസ്, സൈക്കാട്രിസ്റ്റ്, ഇന്ത്യ ഹോസ്പിറ്റൽ. ഡോക്ടർ മുഹമ്മദ് സിറാജ്, MMC ഹോസ്പിറ്റൽ, മയ്യിൽ.
ഡോക്ടർ ഇനാസ്, ഓർത്തോപീഡിക് സർജൻ ആണ്, സ്കൈ ഹോസ്പിറ്റൽ ഇരിട്ടി.
ഡോക്ടർ ജിമ്മി, ഹോസ്പിറ്റൽ, മീൻസ്.
നമ്മുടെ സെക്രട്ടറി ഓഫ് ഇതിന്റെ ആക്ടിംഗ് നമ്മുടെ
So I invite Mohammed sir to please.